Hey everybody, I'm Dr. Deed Harrison. I am president of Chiropractic BioPhysics Seminars and Technique, and I'm also president of Chiropractic BioPhysics Nonprofit, a spine research foundation. What we've been doing, if you've been following us on these videos, we've been going through each one of the Cbp Nonprofit research publications in a proper video format. Now, I still think it's a great idea for you to read these particular papers so you get a true understanding of exactly what was done. However, the videos that we're doing will absolutely be enough of an overview for you to grab an understanding of what it is that Cbp Nonprofit is all about and what each particular project is all about and how it ties into the entire process of what we've been doing for the last 25 plus years. We've published just over 150 peer-reviewed research publications. Shown on this particular list is 147 of the research projects in the different journals that we've been in. Also, the letters to the editor, the peer-reviewed letters that we've written as a team of Cbp Nonprofit researchers. So without further ado, we're going to go through this week's presentation. This particular study was in 1999, clinical biomechanics. Myself, Dr. Deed Harrison, I was the lead author, but of course, one person cannot do the project. Always, we have a team of researchers that are each contributing different aspects of the project based on their expertise and understanding. So the title of this week's paper, Lumbar Coupling During Lateral Translations of the Thoracic Cage Relative to a Fixed Pelvis, by myself, Dr. Renee Caillet, MD Physiatrist, my late father, Dr. Donald Harrison, Dr. Tad Yannick, PhD Mathematics, Steve Taranovich, a chiropractor, and Roger Coleman, a chiropractor. This particular project, it's not necessarily a really exciting or profound project, but it is a background project, a platform from which we can look at the definition of what a normal spine should look like under certain postural displacements, and then we can compare patients with chronic low back pain or some type of condition, we can compare them to these normal data sets. That way we get an understanding of how to approach treatment with these types of populations. Is it a straightforward, simple case, or is it a more complicated case? The only way to know is to have background studies like this that give us normative data sets, specifically looking at how the low back and pelvis should appear on an x-ray under a certain postural displacement. The certain postural displacement that we're interested in this week is called lateral thoracic translation of the rib cage relative to the pelvis. So if you look, this skeletal model shows that the rib cage can translate linearly left or right relative to a fixed pelvis. So the pelvis is the origin or the center, and my rib cage is shifting laterally left or right. Now we can call this a side shift, we can call it a translation, which is really the classic definition of what this movement is. We could call it a lateral shear. Some people call it a trunk list. Either way, the center of gravity of the rib cage is shifted off to one side relative to the center of gravity of the pelvis. Okay, so shown is my younger sister, Stephanie. She's modeling this particular posture. There's certain features that we look for when we're clinically assessing a patient for this posture. Number one, we look for there to be more space between the arm and the rib cage and the arm and the hip on the side that the subject translates to. Number two, oftentimes we'll get a little bit of a high shoulder on the side the subject translates to. The skeletal animation shows a pure linear movement, but in reality most patients don't do that. They'll have a little bit of a tilt high on the side that the thoracic cage translates to, or low on the side away from the pelvic or the thoracic translation. Also, what we want to do is look at what's called the episternal notch and the xiphoid process, and we make a line with those two structures, and we look at that line relative to a line that bisects the pelvis, and we get an idea that, hey, this person is truly translated with their rib cage. Lastly, what we can sometimes see is a little bit of a coupled pelvic tilt. Your sacrum will tilt low on the side your rib cage translates to. That's often because the pelvis is moving the opposite direction of the rib cage. And my legs start to lean just a little bit. The pelvis shifts one way, the rib cage shifts another way. So I get the appearance of a little bit of a lateral tilt in the pelvis. And you can see that in Stephanie the model. This side of the hip looks low, this side of the hip looks high. That's driven by the lateral thoracic translation. Okay, so the methods for this particular project. We wanted to study pure translations without lateral bending or twisting. So what we did is we had a special frame engineered, and this frame would constrain the pelvis in the center of the X-ray film, in the center of the grid cabinet, and then we would ask the subject to shift as far as they could without lateral flexion, and then we'd clamp the rib cage into place. So this is the frame. The frame stops y-axis rotation or twisting of the rib cage and pelvis, and it stops tilting of the rib cage and to some extent the pelvis as well. So we had 17 normal volunteers. Normal meant no history of back pain. They did not have extensive degenerative changes, no instability in the spine. They did not have true leg length inequality on spine radiographs measured more than 10 millimeters. So for all practical purposes, this is a normal group. Smaller sample size, 17 subjects, 15 men, 2 women. What we did is we took 3 x-rays. X-ray number 1 in the neutral position. So the subject adopted their neutral resting stance. We fixed them in the frame, and then we x-rayed them. Then what we did is we had them translate as far as they could to the left, fix them there, x-ray them, translate them as far as they can to the right, fix them there, and x-ray them. So we have 3 x-rays of 17 subjects, meaning 51 films. Now, this project, as with all of our projects, has institutional review board approval. We're not just taking a group of subjects and randomly doing a study on them. Always in research, we use informed consent and an IRB-approved project. Cbp Nonprofit has an IRB. They approve or they deny the ethics of all our projects. This one was approved. Okay, so the x-rays were taken at 60 inches this time, not classically like we do it in clinical setting. Most chiropractors would take an x-ray at 40 inches. This was done at 60 inches so we could minimize the basically the magnification, and also so we could make sure the frame didn't interfere with some of the things we were trying to do. So it was taken at 152.5 centimeters or 60 inches. Now, the possible movements that we're interested in, we cannot see the sagittal plane, so we can't see is the spine flexing or extending. What we're going to see is the movements that can occur in the front view or in what's called the transverse plane. So we're looking at lateral translations. The primary movement of the trunk, it's called the main motion. That's thoracic lateral translation, or what we call TXT, translation of the thorax on the x-axis. We're also expecting to see that movement to some extent in the individual segments of the vertebra. So we're going to measure and assess for lateral translation or lateral shear of the individual segment. That is shown in A. So the method we used is shown in A here. B is rotation about a vertical axis, or what we call rotation Y. We had to develop a special equation unique to our particular methods and our distance for calculating rotation on the y-axis. The reason is y-axis twisting occurs in a plane that is not perpendicular to the x-ray. So here's the x-ray film. The camera that's looking at me is the x-ray source. Lateral translations are in the plane perpendicular to the x-ray source. Lateral tilting is in the plane perpendicular to the x-ray source. But y-axis rotation, twisting, is not. To actually see that, you have to have a bird's eye view. This creates a challenge for us, so what we had to do is come up with an equation to accurately assess for y-axis rotation, and I'll show you how we did that. Then C, the lateral flexion. We just have a simple understanding of the lateral tilt angle of the center of mass or the end plates of each vertebra relative to the one respectively below, a relative lateral flexion angle. So it's really RY that we're primarily concerned about in terms of how do we account for this, how do we assess for this? Well, using known anatomical sizes or dimensions in the literature, specifically from Gilad and Nissan in the 1980s in the Journal of Anatomy, and then Punjabi et al. In Spine in the late 1980s and actually into the 1990s. They published a series of papers on dimensions of spine vertebral segments. And we use that data, and then we look at our population. We see, are our men and women of the same stature, the same height and size as this data set in the literature? And then if we know how far our object film distance is and our source film distance is, then what we can do is we can estimate how much y-axis rotation it would take to theoretically move the spinous process as far lateral to the edge of the vertebral body as possible. So here's a spinous process at L3. We calculated that 40 degrees of rotation would be required to move this spinous process to the lateral margin of L3 vertebral body. So 40 degrees is our upper limit. Now, what we know is we're not going to see anywhere near that, so we have to come up with a way to calculate less than 40 degrees of rotation. And what we do is simply use the width of each vertebra, the narrow-waisted margins, left and right, versus the spinous lamina junction, compared to the vertebra below. So we get an equation that looks like this: C minus A. C is the top vertebra, the spinous lamina junction relative to the lateral aspect of the vertebral body on the side that the spinous rotated to. That's distance C. A is the vertebra below, assuming that it's centered. We go, how far did this rotate? A is the distance spinous lamina junction to the lateral side. So we have distance C of the top vertebra, distance A of the bottom vertebra, the same type of measurement, divided by A plus B. Now, A plus B is the entire width of the bottom vertebral level. And then what we do is we multiply that times 40 degrees, and that gives us our calculated RY. We also presented a model to show that this model was extremely accurate for rotations. Now, under large rotations, the measurement actually becomes inaccurate. Under large rotations exceeding about 10 to 15 degrees, we can't use this particular method. But small rotation angles, we find out that this is extremely accurate in terms of the math. Here's what we identified. The main motion, how far can each subject translate left and right? Well, we identified the average subject can translate 53 millimeters. Okay, that's to the left, and 52 millimeters to the right. That's just over 2 inches. Now, the way we make that measurement, we'll see it on an x-ray coming up, it's T12 center, or the centroid of T12 vertebral body, relative to a vertical line that comes up through S2. So S2 tubercle and the offset of T12 relative to that. This is quite a large movement. Subjects can translate over 2 inches. That's quite large. That's also accounting for magnification. Now here's the kinematic data at the coupled, or what we call the coupled motion. What do the vertebrae actually do themselves aside from this lateral shear, which is the main motion? Okay, here's what we identified. Rotation Z is the largest movement. So lateral flexion is how the spine actually creates translation of the trunk. What we identified is segments below L1 will bend to the side that the rib cage translates to. So if my rib cage translates left, from L1 down, my segments will bend to the left. However, above L1, the segments will bend to the right. So part of the spine bends one way, the other part bends the other way, and it creates the external appearance of a true lateral shift. However, internally, the vertebrae are not translating that much. They're only translating 1 to 2 millimeters. The primary movement is lateral flexion. So look at this. Lateral flexion occurred at L1, L2, relative to L2, L3. It's bending in a direction that's to the same side of the translation. L2, L3 is bending to the same side as well. It's bending approximately 4 to 5 times more than L1, L2. And then L3, L4 is also bending to that same side. If you notice, L3, L4 has the largest relative lateral bending angle. L4, L5 is really close to the same amount of bend as L3, L4. So in essence, what we're seeing is the L3 to L5 segment is contributing the primary magnitude of this displacement. L5, S1 is contributing a little bit, 2 to 3 degrees, and then L2, L3 is close to the mid-lumbar spine. It's at almost 5 degrees, and then you can see it dramatically straightens out at L1, L2, and then reverses direction at T12, L1. So I'll review this coming up and tell you how we actually process this clinically. We jump over to the rotation on the y-axis. The rotation on the y-axis, we found extremely small to non-existent y-axis rotation. The largest y-axis rotation was actually at L4, L5, 1.2 degrees. You'll look at the standard deviation, and what we notice is the standard deviation is actually either a bit larger or it's about the same as the actual measurement, meaning that, you know what, our measurement is not quite sensitive enough to pick up, rotations under a degree, and all these things are really under a degree anyway, so the chances are it's not really moving much in terms of y-axis rotation. That should make sense. Your rib cage is translating, it's not twisting. How it gets to translate is the segments bend in opposite directions, okay? And then we broke down left versus right, and you'll see the approximate same type of movement and approximately the same magnitudes of movement from right to left. There was near symmetry in here as well. And then again, the y-axis rotation, it's less than 1 degree. Okay, so to review, this is our main motion. Oh, sorry, the video decided it wasn't going to play, so we'll try that again. There we go. So we're talking about a trunk translation to one side. This is the posture. We x-ray people that come in with chronic low back pain, chronic leg pain, chronic stomach problems, whatever it is. We're going to look at their body posture. In this case, it's a lateral thoracic translation. Well, we want to take an x-ray to see what the spine really looks like. Well, now we know what the normal subject should look like. The normal subject should look like this x-ray here, where I'm translated off to one side, and what I'll see is approximately at L1, L2, the vertebra below that will bend to the side that the rib cage translates to. Above that, you'll start to see the vertebrae start to bend the other way. This is how the rib cage maintains a true translation. If you look at the spinous processes here, the spinous processes are really close to the midline of the vertebra, meaning there's very little to no y-axis rotation. This is what a normal translation should look like. So in this particular case, this spine matches a lateral thoracic translation. Now, the magnitude of movement that we studied in our project, we identified maximum movement of just over 2 inches or 52 or 53 millimeters, depending on which way they went. This is a real person with chronic back pain. They have 29 millimeters. So how we look at this is we want to look at the severity of the size of the displacement. So in a subject that comes in with pain, we go, wow, you're 29 millimeters translated off center. Let's just round that up to 30 so we have simple math. The average person in our normal subject study could translate 50 millimeters. Let's round it down so we have simple math. So if I look at 30 versus 50, I see that this person is 2/3 of their available range of motion, roughly. It would actually be 60%, right? So 60% of their range of motion. So we go 60% to 2/3, we go, wow, that's a large postural displacement. No wonder they're having X, Y, or Z condition. This displacement is a problem. It creates offset of the center of gravity of the trunk. Your spine muscles now have to contract to support that. The disc pressures go up really high, and you start to get back pain and leg pain, but you can also get other things going on. You got to realize your internal organs are in here. You've got your stomach area. You've got your intestines. intestinal tract, you've got your kidneys, you've got your liver, you've got your spleen, you've got very, very important immune organs in here. You shift over, it's compressing the trunk area over time. This can create some problems in people. You know, we've personally, myself, I've seen patients with diverticulitis. I've seen people with Crohn's disease. I've seen people with irritable bowel syndrome, and they have large thoracic translations. Obviously, the nerves to their stomach are not working right, coming from this area of the spine. You know, if your spine looks like this, you can imagine those nerves are pulled and pinched and twisted and stretched, and then the organs aren't going to work right. And then people think chiropractors are crazy because we claim that we've helped people with different visceral conditions when they correct their spine. We're not crazy. We actually see it happening. There's people out there that would go, yeah, I went to a chiropractor and now I don't have Crohn's disease anymore. We're not making this stuff up. Is it going to happen in every case? No, it's not going to happen in every case. But when your spine's this screwed up, you can bet that there's going to be a consequence. So then that's the clinically relevant side of it. Now back to this. This is what we should see. Ipsilateral lateral bending from L1 to L2 down to the sacral plane. Now this case, this is not a pure normal subject, the x-ray we're looking at. This is a chronic low back pain subject. So you can see their sacral plane is low, it's tilted low on this side. All the vertebrae are tilted to that same side, except you can start to see right in here, it starts to change directions. So that's why I put L1, L2. Now, in our research project with maximum translation, we actually showed the change in direction was T12 to L1. That may not be the case in the typical patient that comes into your office for a couple reasons. Number one, they're not maximally translated. So you can expect the change in direction to be a little lower in their lumbar spine. It might be L1, L2 instead of T12, L1. It might be L2, L3. It might actually be L3, L4. It depends on their unique case. How far did they translate? And it depends on how much degenerative disc disease do they have, how much muscle spasm do they have, etc. Okay, so these are typical appearances of lateral thoracic translations that we see in our patient populations. What we do is we look for the qualitative fit of this spine relative to the data set that we had in clinical biomechanics. And we look at these two x-rays, ignoring the skeletal animation. These are two x-rays of patients with lateral trunk translations as their posture in different health conditions that they came in with. We x-ray them, we look at their spine, we go, hey, it looks like this matches a lateral translation. You'll notice the sacrum is slightly low on the translation side, and you'll notice opposing bending angles in the lumbar spine. The change of direction is somewhere in the mid to the upper lumbar spine. So when we see this, we go, hey, this is classically a lateral translation pattern. You'll notice very little spinous y-axis rotation. Okay, so very little spinous y-axis rotation. That's the typical pattern. Conversely, when we see more complicated cases, these should jump out at you right away and red flag you. We go, whoa, this is not the same thing for a couple reasons. Number one, the change in direction is much more profound. Where the mid-lumbar spine starts to change in direction, you can see a much stronger tilt angle. Okay, so what we call the inflection point. The spine bends one way here, the other way here. At the apex, that's the inflection point where it's changing directions. Also, what you'll note is the spinous processes are really strongly rotated towards one side, in particularly what we call the concavity of the curve. Concavity means the shorter side, okay? So not the convexity, this would be the convexity, this is the concavity. The spinuses are rotated to that side. That should not happen with a simple lateral translation. So right away I look at these cases and I go, whoa, a little more complicated than what should be found in a lateral translation. So a couple things. These patients either have multiple postures of the rib cage, or they have some type of scoliotic deformity that really needs our attention and our efforts to rehabilitate this. Okay? So we look at a hierarchy. Is this a simple, straightforward case, or is this a more complicated case? This is the background, the why we would pursue a project like this in clinical biomechanics. Also, what you have to realize is when we do a biomechanics study like this, so looking at simple kinematics of a posture in the x-ray, we want to also teach you the clinical relevance side of this. When we see this, then we have a treatment protocol that we put a patient through. In addition to adjusting the segments of the spine to get them working and mobile, and in addition to helping the muscles with massage and things like that, let's correct the spine and posture. What a novel statement, right? Let's actually correct the alignment of the spine. If your rib cage is shifted off to one side, that is a big problem. Your rib cage is 2/3 of your body mass. If you're a 200-pound male, your rib cage weighs approximately 120 pounds. Now, if you're a little bit chunky in the middle and you have what I like to call the Harrison starter kit, which is this nice little belly that the Harrison family males get, your center of gravity or your center of mass of the rib cage is a little bit more than 60%. It might actually be 70%. So if you're a 200-pound male, your torso can weigh up to 140 pounds. Now take that 140 pounds, shift it off center, and you wonder why you have a problem, right? You have back pain, you have leg pain, you have stomach problems, and you go, nobody can figure it out. Well, that's because 140 pounds of your body is off to one side. You look at this and you go, duh, it's common sense, right? How do people miss that? Well, what we do is we look at it and we go, well, if your rib cage is shifted off center, we take an x-ray and your spine matches that particular pattern that we've just reviewed, the treatment is actually very easy and straightforward. It needs to be directed and guided by somebody that knows what they're doing, but the treatment is really straightforward. What we do is we teach you how to exercise your body back towards neutral. We call it mirror image exercise. Mirror image really means do the exact opposite. My late father, Dr. Don Harrison, said this. A lot of people thought, man, this CBP technique is too complicated. It's a lot of math and engineering and science. And my dad goes, the application of the technique is not that hard. If you see it shifted one way, shift it the other way. The science behind it is quite challenging, but the reality of the treatment is not challenging. Mirror image exercise. Then we have adjusting. Adjusting is where the chiropractor on the table will put your body in the exact opposite position and will apply controlled forces on our drop table or using an instrument. Now, it might look uncomfortable. It's actually very, very painless. It doesn't hurt. Okay, so what we're doing is we're shifting the person, their rib cage towards their left relative to the fixed pelvis. That's because they have a rib cage shift to the right. And then shown here is what we call traction. Traction is positioning the body in its opposite structural position from where it starts, holding it there and leaving it there for 5 to 10 minutes. That's traction. It's sustained loading. Loading over time stretches the tissue, the muscle, and the ligament back towards where it needs to go. So in CBP, we call this the EAT protocol: exercise, adjust, and traction. That's what we do to correct these types of lateral translation displacements. Again, the treatment is straightforward. It needs to be done by somebody that knows what they're doing. It's not rocket science, but the background, the science behind it can get kind of involved. So that's why I throw this at you and show you the technique, outcomes, and application. So an example of the actual outcomes. We take somebody with a condition like chronic pain or chronic digestive disorder. They have a large lateral translation. We take an x-ray. We go, whoa, that's not where it should be. 29 millimeters off center, roughly 60% displaced. Then we do a treatment protocol 3 to 4 times a week for 9 to 12 weeks. We teach you how to do these exercises. We do the adjustments with you. You do the traction, and then we reevaluate you. We reevaluate your pain, your posture, your health, and we also look at your function, and we reevaluate you with x-ray because we want to make sure we corrected you. In this case, shows a nice correction. This is down to 5 millimeters. Certainly, you could argue that 5 millimeters might be within tolerance of the system. You got to take that on as a case-by-case basis and see how the person's doing. This case is great, so happy day. So there's the application of this particular research project. The conclusions of our particular project in 1999 go like this. Lateral translations of the trunk are relatively large movements, just over 2 inches each way, left and right. Lateral flexion is the primary coupled movement that causes translation to appear. So the vertebrae themselves only translate a small amount, they only twist a small amount. The primary movement is tilting, okay? The vertebra below L1 with maximum translation showed bending to the same side as the ribcage translation, indicating that L1 body actually had the largest relative tilt to the sacral plane, okay? The change in direction is just above L1. Thus, return to vertical starts typically at T12. So if we x-rayed higher in the rib cage, you would see the tilting starting to come back the other way as high as like T8. You'll see that's what creates the rib cage actually being neutral. So my lower lumbars bend this way, and then right at T12 they start to bend the other way all the way up to about T8. Okay? The maximum relative rotation angle, the segmental displacement, was at L3, L4, but L4, L5 was quite large too. This has implications for disc injuries and disc herniations. L3, L4 and L4, L5 are common sites for spine injury. If I see a large displacement there, this can contribute to the location of that injury or the disc herniation. Okay, so let's keep that in mind. Translations can produce a lot of stress on these disc herniations that are occurring at L3, L4 and L4, L5. And then lastly, knowledge of normal mechanics aids the clinician in understanding and directing treatment for spine injuries. And I've talked to you a little bit about that particular application. Obviously, there's a bit more to it, but trying to keep these videos as short as possible, and that's very difficult for somebody like me. Short is 25 to 35 minutes. Hopefully you've enjoyed this week's presentation. If you do, please consider, or if you did, please consider supporting CBP nonprofit research, and please consider, if you're a patient out there, going to a CBP trained chiropractor. If you're not getting help where you're going, there is an answer for you. You just got to seek out the right person, the right practitioner that can identify what's going on. Thank you for your time and attention. I'll talk to you next week. If you like this information, if you're a patient, you need to go to a Chiropractic BioPhysics trained chiropractor. You can find us all over the United States, Canada, and international locations. Go to www.cbppatient.com and look up CBP providers in your area. It's an easy-to-use, user-friendly site. Search for, at first, a general or advanced trained CBP chiropractor. If you can't find one of those, then find somebody that's at least on the directory and has taken our courses and that does the work, okay? So let's go to a CBP trained chiropractor, www.cbppatient.com. If you're a chiropractor and you're interested in this, either learning more about it or maybe it's brand new to you and this particular video research project intrigues you, come to our website for doctors. Go to idealspine.com. We've got a lot of things there for you. We've got training, we've got conferences, we've got products. Love to have you on board and become one of the CBP doctor family providers, right? We need your help. There's patients out there that need you, and if you don't get trained in this work, then you're not going to be able to provide them the type of service that we think you should be providing them from a corrective care point of view. Also, lastly, anybody out there, we also need your help to continue to do research investigations like this, right? These are time and dollar consuming projects. If you will, go to our website directly and sponsor and support Chiropractic BioPhysics nonprofit. Make a donation of any amount to us. Also, you can do it indirectly on Amazon Smile. Just select Chiropractic BioPhysics as your nonprofit foundation, and when you purchase through Amazon Smile and Amazon, CBP nonprofit will get 0.5% of all your purchases, which is a big deal. It adds.